Okay, so we're recording.
On a l'air techno nul.
Bonsoir participants.
Non, c'est ça.
So we have 7 people, I think.
8.
8, okay.
9.
So we're just going to hold off just for a minute or two, see if there are a few other people. Well, I think we'll get started.
Oui.
And likely we'll have some people. I know there were some people who did let me know they would probably be joining a bit later. So hello, thank you for joining us for this webinar. For co-investigators and project partners, the purpose of the webinar is to give you an overview of our study proposal, Adaptation of a Structural Intervention to Improve Access to Combination Prevention for Men who have sex with men in 4 Canadian cities. I'm Thomas Haig. I'm the National Study Coordinator. I'm based at the Université du Québec à Montréal and at COXIDA. And I'm my co-presenter.
Joanne Otis, professor at Université du Québec à Montréal, and I will be there with you to lead this project, this fantastic adventure.
And we have some assistance, Aurélie Ott from COXIDA, who you can't see, but is in this room helping some other things to note questions that you may be asking. And we have a couple of other friends sitting around the table who will be quiet as mice, but are also here to learn more about the project. So just some technical information. We're recording the webinar, and both the recording and the PowerPoint slides will be made available. The webinar we hope will last a maximum of an hour and a quarter, including time for questions and comments. You can make questions and comments at any time. We can't hear you, so the way to do that is to type in the chat box in the bottom left of the screen. We may not be able to deal with all questions that you submit, but we will save them and look at them later, just for time constraints. So we'll probably maybe have time for 1 or 2 questions each time we stop. Just to take a moment to test the chat function. So the people who are on the webinar, if you want to just type a quick hello into the chat window, and we can make sure that that is working. Hello, hi from Toronto, great.
Ok, marqué, c'est bon. Can...
Excellent, all right. So as you can see on this slide, we're fortunate to already have a large number of people participating in the project. I think I counted 50, either as co-investigators, partners, or collaborators. An important aspect of the project is building a broad-based coalition in each city. that really brings together people from the community and key stakeholders from different sectors working in prevention. So it's important, and we invite you to start thinking about who's not on this list, but who you think has a role to play in the project. And we're hoping that over the next few months we can start to invite additional partners and collaborators in each of your contexts. So we're going to do just a very quick poll to get an idea of who's on the call. So I'm just going to launch a little survey and invite you to just respond in terms of the city where you are based. Just give you a minute or two to respond. Okay, so it just gives us a bit of an idea of who's able to make it today. And again, it's just as a first step in really starting to communicate what this project is about, and we'll be using much more interactive formats, obviously, in the future to discuss what we're presenting today. All right. So the goals of the webinar, we of course want to give you some background and a general overview of the project, and really start to think about how to collaborate on the national and the local levels, what kind of operating structure we might want, governance we'd like to put in place. And as some of you know already, Joanne will be making a trip to each of the other cities in June to hold one-day working meetings. We'll give you the exact dates of those meetings at the end with the study calendar. So this webinar is also a way to help prepare the ground for these meetings. I think, Joanne, do you want to add a word about?
Not now, but at the end, maybe we can precise together the agenda for this first and important meeting in June. And maybe just for starting the meeting today, just remember that what we will share today is just a proposal. I think we have to take time to better define and precise exactly what we want to do with this project. We have 1 year to plan something really important, and yes, we propose something today, but a lot of things can change, and that's in French we say that's a co-construction. That's something we will do together. So that's a start. Yep. That's all.
Okay. So the agenda specific today, the background, overview of the project, and we're going to spend some time to review each phase of the research program, especially talking about phase 1 because it's one of the immediate priorities, but touching on the other phases. We'll look at a proposal for the study calendar and touch on structure and governance and the question of what to name the project in the conclusion. If anyone has any points they wanted to add or something wanted to raise before we get going, feel free to let us know. Sounds like that's good, or looks like we're good to go. So just, oh, synergie, okay. Did you write something and we didn't see it? Okay.
No.
Okay, you talk synergy between all activities around MSM and prevention, actually. Yes, yes.
Okay.
Okay.
So if you could help us, it's Roberto, who you can't see, who brought this point, but if you could help to remind us at the end to maybe just add that to the things we want to remember as we go forward. So clearly, an important starting point is the epidemiological situation and the ongoing impact of HIV among men who have sex with men in Canada. HIV incidence has changed very little, which raises important questions about what we need to do to increase the effectiveness of prevention strategies, the prevention strategies we've been using over the past number of years, and particularly in light of new prevention options such as PrEP that are starting to become available and that many people in Canada are working very hard to increase in terms of availability. And also an understanding of the co-occurring health problems or syndemics that affect MSM and have led to an increasing interest in how we can implement and increase access to combination prevention approaches. So this is the UNAIDS definition of combination HIV prevention, and at the heart of this approach is clearly the diversification of prevention options. So yes, the condom, but in addition to and beyond use of the condom. And also the notion of using different options together in a strategic way. So prevention strategy, and also really paying attention to the structural aspects of our prevention efforts and the social aspects. So in addition to working on the individual and interpersonal levels, we need to find ways to take action together on the community, social, and structural levels. So in practice, there are clearly a lot of things to consider, most especially true access to a range of effective prevention options, and also access to effective ways of combining these different options together. So that's really in part the intersectoral aspect. We need to find ways to get different stakeholders to work together and work together in a coherent and coordinated way. So we've just listed here some of the things that, that are necessary and important for this to happen. And because access is central, we're using this model for access to health services as really one of the main conceptual underpinnings for the project. And we're not going to take the time to go over this in detail right now. We encourage you to have a look at the article by Levesque, Harris, and Russell if you haven't had the chance to previously. It's listed in the references with the funding proposal. We can also, I'm happy to just email you the PDF if you let me know. But in general, what this model highlights are the multiple factors that have an influence on access to service. So the top part of the model, really focusing on the service provider's perspective, to what extent are services approachable, acceptable, available at appropriate times, appropriate locations, affordable. So those kinds of issues. And the bottom part focuses on the service user's perspective. So to what extent can people identify their health needs, make use of services to respond to these needs, afford these services if costs are involved, etc. So both of these converging in this model to determine and help us understand the extent to which people can actually access and make use of the services that they need. So just pause for a moment if anyone has any questions or comments on that. So moving on to an overview of the project. And the goal of the study, so guided by that conceptual model that we've just looked at, this study focuses on how to improve access to combination prevention for MSM. And because we hope to continue the project and apply to CIHR for component 2 funding, what we need to accomplish in component 1 is to identify promising combination prevention models in each city, and then put in place the right conditions so that these models can be implemented and evaluated in component 2. So to achieve this goal, we have a number of objectives. Again, I won't read them all in detail, but just to highlight a few things. As we mentioned just a minute ago, a key priority is building multi-sectoral coalitions that we'll need in each city in order to push for changes and truly have impact as a structural intervention. Social and community mobilization and empowerment are also crucial and very central to this effort. and developing a very systematic but also appropriate evaluation process. And the evaluation process itself is really one of the main ways main mechanisms that we want to use to effect change. So this leads us to the methodology. We have benefits, but also the complexity of being a multi-site study. So with these 4 diverse contexts, we're really anticipating there will be a lot of differences in the approaches and the models that are going to make sense in each city. As I just mentioned, the method really focuses on an evaluation process to improve access to combination prevention, and an emphasis on integrating the relationship and the integration and intersection of knowledge production and knowledge translation. So really we're clearly very much in the vein of action research, and I think you'll see in a few minutes when we talk a bit more about Mobilise, partly what this is about is finding ways to really re-inject the knowledge, the information, the data that we're producing at different phases directly back into the project, and that will help us to advance to the next phase. And also feed into the community and social mobilization processes that we really want to develop. We hope this will make a certain degree of consensus possible, so there are obviously going to be a lot of methods that are process of discussion, deliberation, that the project doesn't hinge on actually arriving at an absolute consensus, and I think we really want to build in some flexibility even as we move towards obviously shared and common understandings of what the problems are and what the solutions need to be. So it's a breakdown of the phases of the research program, and again you can see the 2 columns, KP, knowledge production, and the knowledge translation, KT, which really converge in terms of the outcomes that we want to have. Phase 1 is focused on adapting strategies for community mobilization, empowerment, knowledge transfer that we've been developing in Montreal. Phase 2, the focus on an analysis of socio-political contexts in each city, and also identifying subgroups that we most need to reach. Phase 3 on development of indicators adapted to each city to evaluate access to prevention services. And the orange color for phase 3 is really just referring to sources of funding. So phases 3 and 4 are not funded through the component 1 grant from CIHR, but instead through Catalyst grant and also a grant from REACH 2.0. So in phase 4, we will use the indicators developed in phase 3, as well as ethnographic methods to actually do an evaluation of access to existing prevention services in each city. Phase 5 will really consolidate what we've learned and start to identify promising combination prevention models for each city that will be the focus of component 2. And phase 6 will pull all these strands together, and the emphasis will be on selecting the best evaluation framework and packaging this together to make our submission to CIHR for component 2 funding.
Maybe just to add that these phases are not chronological, okay, because a lot of phases have to be accomplished simultaneously. So we'll see together at what moment that's better to do the job.
So I hope you're all still with us. Again, just a moment if there are anyone wants to comment, ask a question. Okay. So, sorry, which I cannot see. Could someone, sorry. This is where my technical challenges come into play. I honestly don't even know where to look. Could you? Okay. Oh, thank you. Okay. So, okay, I think this was maybe some technical difficulties, but there's Okay, all right. Hopefully, Barry, you can come back.
Okay.
All right. So phase one, adaptation of community mobilization and knowledge production transfer strategies. So for each phase, we've identified specific research questions. Phase one, the main question is how the mobilization strategies that we've developed in Montreal can be adapted to the other cities. And a couple of slides from now, I'll give you a bit more detailed information about those strategies. And this discussion on how to do the adaptation will be, of course, one of the focuses when Joanne holds meetings in each of the cities in June. And really, and this kind of touches on what another aspect of what Joanne mentioned, but it's not all going to be about sort of just exporting and replicating literally the Mobilise project in the other cities. That definitely could be an avenue if people in other cities say, hey, this will really work. But more likely, it's going to be really looking at what's happening already in each of the different contexts and using Mobilise as a starting point to develop things that are adapted or strategies that are very adapted to each context. So we're using a discussion group process to work on this adaptation. And to sort of help clarify how to approach this, we wanted to just take a few minutes to talk about the theory and process of adapting and intervention. It's an emerging field, replication science, and a range of guidelines and planning tools that can be used to help. Specifically in terms of how to approach the adaptation process while ensuring intervention fidelity. So this is a common analogy for thinking about the distinction and the relationship between, on one hand, the adaptation of an intervention to a new context, so the kind of leafy above ground part of the tree, and then maintaining, on the other hand, sufficient fidelity to the original intervention, so that the root system of the tree. So fidelity refers to the importance of retaining those aspects of the original intervention that made it effective, and these are referred to as core elements, and in particular this refers to the theoretical underpinnings of the intervention and its internal logic. Focus on adaptation is modifying an intervention so that it's appropriate to the new context in which it's being implemented. So this can involve cultural adaptation or adapting to different circumstances, adapting to behavioral factors, and all this is referred to as modification of the intervention's key characteristics. An important thing to note is, of course, we want this adaptation to happen without contradicting or competing with the core elements of the intervention. And we also need to pay attention to the issue of discordances between the original intervention and the new setting in which we want to use it. So it might be necessary to make changes to an intervention with respect to goals and objectives or target population or the setting, either organizationally or in the community context. So these different factors may need to, or key characteristics may need to be changed in order to reduce discordance. So in terms of our project and the intervention that we want to implement and evaluate in 4 different contexts, we'll be working and needing to find a balance between maintaining sufficient fidelity to the core elements of the intervention and ensuring at the same time that the key characteristics are adapted sufficiently and adequately so that the intervention is relevant and appropriate in each context. So we want to flesh it out a little bit more in terms of our project. This is the logic model of the Mobilise project, and I want to ask Joanne to just maybe walk us through this quickly and highlight some of the most important aspects. And of course, it's tiny on the screen. We apologize. There is obviously a copy of this in the documents, and we can forward this to you if you're missing this at a later time.
Okay, anyway, what we have to understand with the theory of adaptation of health intervention is really this balance between core element and key characteristics. And so in each city, we will have to respect the hypothesis we have actually on access, and this logic model has to be respected. But after that, how we will respect the model, it can be really free, and it depends on the strand in each city and of the picture we will have when we will have this meeting in June and after. So I think what we have to respect is first create this mobilization, because that's the first process we want to put on. And the other process is this dialogue between us, helping us to create some knowledge about the intervention and the best way to do these things, and the application of this knowledge. So if we respect these two processes, anyway, how we will do that in each city, we will be in the Mobilize project principle, okay? So that's the first process we have to respect. And after, what this model say, that's we want to go with the process of empowering individual MSM, their organization, and also the community by itself. And why? That's because we think the leverage of knowledge production and knowledge transfer and the mobilization will push a pressure on the access of services. So we have to push to enhance the demand of these services, but in the same time, we have to consolidate the offer of the services. So that's for this reason we have to create this space of deliberation between communities, members, and stakeholders, and everything. So that's the logic model. That's the core element we have to respect. And after, we have to adapt our strategies to go in this way. That's all.
Thank you. That was excellent.
Thank you, Thomas.
And I've seen the chat. Unfortunately, there were a few people who did lose connection. There were some technical problems with the system this morning, and it's not our system. That's what I wanted to say. Was we were on the phone this morning with the company, and it seems there's unfortunately some instability on their side. But as I said, we're recording the webinar, and I'll make it available to you right away, so at least you can go back and see what you missed. So apologies for those glitches. All right.
Oh, it's flat.
So core elements, but now let's look just quickly at the key characteristics of Mobilize. So I'm just going to quickly run through, and I'm really going to try and control myself, because I could, I think, talk about this for hours, but I won't.
No, you won't, because when I will go in June,
right.
I will come with all tools we develop, we will experiment a lot of things, and it will be more easy for all people to capture what we are doing actually.
Exactly. So this will give you a taste, whet your appetite. So specifically the strategies for community mobilization, and for, again, the integration of knowledge production and knowledge transfer into a deliberative process. So really this idea of deliberation and hopefully leading to transformative action. So we're placing a lot of importance on using evidence-based approach. So it's a real key starting point for these strategies as well. And the beginning was really having a look at scientific literature on existing and emerging HIV prevention strategies. We really wanted to see what's been studied, what's been published, what we know about the effectiveness, the perceptions, the use of different strategies. And through this, we were able to identify 23 different strategies for which there's some scientific literature that's been published, so including biomedical options, behavioral strategies, as well as social and structural approaches. So this gave us a base for creating a community discussion kit, so that's one of the things Joanne will bring with her on her travels, and in particular a set of prevention strategy game cards, and I've just put on the screen the front and back of one of those cards. You'll have a chance to see the full set. And this has turned out to be a really great tool, an effective way of getting people interested and engaged in discussions about prevention, sexual health, access to services. It's game cards because we also have created, I mean, we call them games, but they're discussion tools in which people are able to use the cards and think about use of the strategies and access to them. We also developed a bilingual website, and you can actually get a sense of the information that we pulled together on each of the strategies. There's a section of the website called Get Equipped, where we really give specific information for each strategy. With our discussion kit, we developed a training session for community members who have a mandate to then go out and recruit small, informal groups of people from their own social networks, and we call these community teams, or in French, équipes citoyennes. The goal is to bring together these small groups and have a 2 to 3 hour discussion activity using the materials we've created. We created a data collection process and some tools for the team leaders so that they can document what comes up in the discussion and to feed that into the project. We're also just about to launch an online questionnaire, again, focused on people's knowledge and perceptions and use of various prevention strategies and barriers of access to services, and this will complement, I mean, those are the same themes that are touched on in the community discussion groups, so those two data collection approaches will really complement one another. The questionnaire probably will be launched, we hope, the very beginning of next week. We're looking to have about 1,000 respondents from Montreal and potentially from across Quebec over the next few months. We also have a number of artists and photographers in the community, as well as a filmmaker, that people have become interested in the project and have been participating in different ways, among other things, photographers who have really graciously donated photographs that we are using in our different promotional campaigns. And we've also been publishing articles about mobilities and about combination prevention and access to services on pretty much a monthly basis in Haig, which is the local LGBT community magazine.
The role of Haig will be really important in the next phase of the project when we will get data. Haig can be really involved in more media advocacy strategies. We will develop something with them.
So just to finish up with the key characteristics of Mobilise, so the top photo of this slide is from the first Soirée Mobilise that we held in the middle of March. It took place in a pub in the gay village. We actually filled the place to capacity. It was a wintry March night when usually there's maybe 2 or 3 people. It was a Wednesday. And a lot of people turned up, so that was, you know, a good indication that something is happening in terms of this project and people are interested and engaged. The Soirée Mobilise, they're community events open to anyone, and the main goal is to really have the discussion team leaders who have led these small group discussions in their own context come together and share some of the highlights of the discussions that they had with people in their communities with a wider audience. So they're really the focus. We don't have experts who get up and show PowerPoints and give information. It's really hearing directly from the people participating in the project. We also have great food, an information kiosk, a DJ, so they're really also intended to be fun and social events. And all this is leading up to a community forum that we're planning for mid-October, that will allow us to bring together and look at some of the data that we've collected. We're hoping that a group of about 100 or 150 people will attend. Again, it will be very mixed. Really a place for people from the community, a place for people from community organizations, from sort of all the settings where people work in prevention, so from clinicians as well, and just really have a very broad-based participation and use in this forum a participatory and deliberative process to start to identify, well, really, I think, work through the issues, but also identify promising and emerging models for prevention combination adapted to the Montreal context. And this will lead to action plans to start developing and assessing these models, action plans that will start to implement and follow up to the forum. In the summer of 2017, we plan to hold a community summit, so reporting on some of the outcomes of the action plans and prioritizing next steps. And we're cautiously optimistic that this is going to be something we can do in conjunction with Canada Pride, which is happening in Montreal in August of 2017. So it will be another important moment of convergence and synergy between this project and a lot of other kind of related efforts. Put at the bottom of the screen, if you're interested in subscribing, there's the link there if you're interested in subscribing to our newsletter. If you do it in the next few days, you'll see the official launch of the questionnaire and get a sense of the type of communication that we're doing for this project. So again, any questions, comments? Okay. So we have a question from Mathieu. I think it's a question for Joanne.
Okay.
What would be an example of an acceptable level of discordance between sites or between different specific populations? So what's the acceptable level of discordance?
That's really hard to answer, because if we are able to respect the logic model and the objective of this model, I think the discordance can be high on the strategies we are implemented. That's not the problem. But the importance is not also to respect à tout prix. Je sais pas comment dire.
At all costs.
Yeah, the model we propose, because in fact, if intervention is se transform is yeah, that's not a big deal, because it will be really adapted at the needs of the community, and that's the more important thing. So mobilize is mobilize, and if mobilize begin to be other thing, it will be other thing than mobilize. That's all. We have to work together to enhance the access and to empowerment the community. So if it takes another form, it will be acceptable from an ethical point of view of the community. So we work together. We think actually we have a nice, a good hypothesis to do this work. But maybe when we work together, we will realize that something is missing and we have to go another way, and that will be acceptable. If we are not doing this, I think we will make a big mistake. So that's for this reason we are together. Mm-hmm. I'm not sure I answered the question.
I think, oh, okay. Okay, well that's an interesting comment. So very, with loss of print, so there's no print version of Extra in 3 cities, there's no Fugue equivalent. So clearly, yeah, it's that one of the differences between our settings, because we, obviously Fugue is a real institution in Montreal, and it really serves a purpose. So.
That's the objective. We have to find in each community their strengths and to focus on their strengths. Right. Here we have Fugue, that's a great thing. but I'm sure in each city we will find a way to pursue the same objective, but with another strategies.
Right. Okay, so I think we'll move on, and we don't have a lot of time left. So really, we're going to go through the next the remaining phases, but I'm going to kind of breeze through them a bit more quickly, and we'll have a bit of time at the end to maybe continue with this exchange. So phase 2. Prioritization of subgroups and analysis of the socio-political context. So the main questions here have to do with understanding the context specific to each study site with respect to social, political, organizational dimensions, of which there are a number that are important, and also with respect to what MSN and what people in the community need in terms of combination prevention. So this is obviously partly about compiling and analyzing a lot of existing data, some of which probably has never really been brought together before. And also a discussion process and specifically use of a nominal group methodology, which will be a way to help us focus in and identify the subgroups within the MSO population that we most need to perhaps focus on and reach. So phase 3, validation of indicators to assess access to existing services. So this will involve adapting a set of preliminary indicators, again, that were initially developed in Montreal. And we're working on a process to really look at how they may need to change and be adapted to each of the other contexts. And this links back to the conceptual model for access to healthcare that we looked at briefly at the start of the webinar. So we'll have focus group discussions in each city that will be starting up fairly soon, and also use of a Delphi method. So basically it's an efficient way to consult with a group of experts and stakeholders by email, I think generally, over a number of weeks, and develop a consensus using a ranking process.
In fact, we are really ready to go with these activities. So Mark Hall and Daryl Tan work with me in the last weeks to prepare all material for these focus group. So it will be really soon.
So on to phase 4, evaluation of access to existing services. So this is really the heart of the evaluative effort. So the questions here have to do with identifying the prevention and sexual health services that already exist for MSN in each location, and an evaluation process to assess access to these services. And also starting to determine which of the existing services are the most likely or most kind of optimal candidates for integration into a model for improving access to combination prevention. So to do this in part, we'll be using an ethnographic process that will allow us to document and characterize access from the perspective of MSM as users of these services. And also a discussion process. So we use the indicators that we'll be validating in phase 3, and now in phase 4 we'll actually make use of them, and what is called a credible judgment method to identify some participatory process of evaluation to identify the services that can most readily be incorporated into a combination prevention approach. Okay. Okay, why not use concept mapping in place of Delphi?
Parce qu'on connaît pas ça.
Because
Yes, maybe.
I think we're open to learning about it. Sure. Yeah.
Yeah. So can you? Oh no, il peut pas.
Okay. Well, but
yeah, we will
note
see. We will
that
see.
if you can provide us with more information about that, I think it's
Okay.
I think there's lots of room to adapt methodologically as we move forward.
So maybe this week we will send at all of you this part of the methodology, because we have a document better explain this phase 3 and phase 4. So yes, if that's possible to confront this method at another, it can be really a nice idea.
Explain the ethnographic methods. Daniel, you'd like a bit more detail on the ethnographic methods.
Yes. Okay. So we will use that's more a mixed method with an ethnographic part. So when we will finish the mapping, the scan of all services, and services we are looking for are PrEP testing, sexual risk reduction counseling, sexual health counseling, and access at addiction centers, mental health issues, violence, domestic violence, and also social exclusion and discrimination services for rights or something like that. So this scan will be done by a guy searching on internet and on different source to have an inventory of these services. But after, we will use the simulated client or sentinel patient to go trying to access at each services we identify, and these guy will comment their experience. They will say takes a long time to access at these services. I was not able to find the good information when I came. They don't understand my needs, or I have. So they will document. They will raconter. They will tell their experience, and after we will follow. We will monitor this, to be sure to have 2 or 3 guys trying to accessing at the same services, and after we will be together and we will share all information we will get from the scan from these experience, and we will with the indicators we develop and we validate with the focus group, we will try to characterize access at this services on the approachability, because we will have a lot of indicators for that, on acceptability and these kind of things. So the ethnographic part is more based on the sentinel patient or a simulated client experience. But we prefer the sentinel patient experience, because it will be based on real try to access. And we'll also use here in Quebec, we have the opportunity to be able to tell a story like that on the Observatoire, on the Portail VIH. So we will see in each city how we can optimize the C'est bien dur.
I think it's you're doing great.
That's clear.
Yes.
Okay.
So, and I just want to take a moment to read a comment from Barry, and then we'll move on to the other phases. So Barry writes, in Toronto, we will need to articulate with several current initiatives. For example, David Brennan's Cruising Counts 2, looking at health access, and the AIDS Bureau ASO OHTN initiative to coordinate, develop a community of practice among therapists and counselors. So that's really interesting. Wow. Okay.
No, that's
So,
trend
yeah.
that we have to focus on.
Yeah. Okay, and I've got a time reminder, so I'm going to keep us moving here. All right. So phase 5. So selection of optimal combination prevention models in each of the 4 contexts. So here we'll be examining what is likely to facilitate a combination prevention approach and what are the barriers, both within and across organizations. And the point is to help us focus in on changes that need to be made, perhaps at the interventional level, perhaps at the service level, certainly at the structural level, in order to come up with a proposed and workable and promising model or models. Methods will include interviews with service providers, in particular the service providers who were identified in phase 4. So phase 4 ends with looking at what are the optimal, seem to be the optimal services for combination. So going out and talking to these people and learning more about their contexts and their issues. And leading to a meeting where we'll consolidate really one or more combination prevention models for each study site, and move on to phase 6, selection of an evaluation framework and planning for component 2. And we've actually started doing some of the work in terms of the evaluation design and looking at the potential to use mathematical modeling. And clearly what we're working on overall in this project is the implementation and assessment of a complex structural intervention. So that's partly, I think, where we're getting going now, because we really need to develop an appropriate evaluation framework for that type of intervention. And phase 6 will also involve fleshing out the proposed models that we came up with in phase 5, looking at how they can actually be operationalized, implemented in each context. So it's a planning phase, and the main outcome will be our component 2 funding application.
So this week we will have a meeting with Marie-Claude Boilly and Shamirsta Mishra about the relevance of a reflection about mathematical modeling. But in fact, our outcomes, our effects will be on the access, on the systemic point of view, with approachability and all these things, and from the point of view of the MSM by themselves. But in fact, maybe it can be a good idea on 5 or 6 years to see if it's possible to take a look on the HIV incidence. And it's for this reason we will have a reflection with these person. But we will see. And we have also the opportunity to go with social network analysis on the services, and to have a point of view of contributory analysis for evaluation. So that's just some piste, just some ideas, but I think we have to begin to discuss that now if we want to have all information we need for the phase 2, the component 2 of implementation science things.
Okay, so I'm not seeing any additional questions at this point, so I'm just going to keep us moving and talk briefly about the study calendar. And again, reminding everyone that we're really still at the proposal stage in terms of how we attack this project. And also, I realize it's probably not that easy to read. So the idea is not to have you kind of assimilate all of this right now and comment on it, but to give you an idea. And again, in June, I think one of the focuses will also be looking at the details of the calendar and really hearing from you in your different settings, to what extent is this doable, what adjustments we might need to make, among other things. And you'll see at the bottom, so I put the dates for the 3 meetings in June, which again, we'll send that information to you by email as well. But one of the things we're thinking about now is the length. So for the moment, this is a calendar for 12 months. Do we want to extend that to 18 months? It might be a challenge to do that given some of our budget constraints, but it might be advantageous in giving a lot more time for exchange, especially exchange, I think, between the study sites, sort of learning about the models that are emerging elsewhere, and maybe some more time to think about how do we pull this together for component to what models are emerging that we want to focus on in that next component of the work. So, we're almost at the end. A few points on structure, governance, and I'm sure people also have probably some really great ideas, suggestions, ideas about how to approach this. So, but we're starting to think about what are the tools and mechanisms we need. There is an operations manual that's close to completion. That will really help each study team and especially the research staff in each location to do their work and to collaborate together. Setting up a shared folder on Dropbox or somewhere similar, and you likely have some other ideas and proposals in this vein. So structure and governance, so thinking about what type of committee structure we might need on the local level, on the national level, what would work best. And especially, I think, what is needed to facilitate people's involvement and participation in the project. The committees are important, but only in so much as they help that to happen. So, and there may be other ways that we want to think about involvement and participation and what can help along those lines. So really opening up that, not necessarily today for the webinar, but in upcoming weeks for any and all suggestions, and especially, you know, what kind of good experience do you have with different approaches that we can feed into this project. And finally, an important question, okay. We've got one comment from Valerie. A paper on data sharing policy could be useful for the team. Okay, great. There's a link to an article that we can check out. Thank you. Excellent. So, and yeah, so one question as well is what name should we give to this project? I think obviously the full title of the study is quite long and unwieldy, so do people have any sort of thoughts? Have you hit on a name that you think, you know, something that makes sense in terms of the project, something that's not going to compete with other studies ongoing, but will sort of communicate what we're trying to achieve. So definitely we'll be working on brainstorming and coming to a decision about that in the coming weeks or perhaps over the summer. So we're nearing the end of our time. One point that was raised at the beginning was the question of synergy or synergy. And I think what you were referring to, as Roberto mentioned, that was because we know that there are several really extensive and important studies going on, engage, and so another level of this is to really think about how these different projects are going to intersect. And we've thought about that at the community level in Montreal to some extent. Roberto actually wrote up a great article that we published in Haig to talk about the various research projects that are going on in the community and explain to people a bit more about how they intersect and how they complement one another. So, because one of the things that is of concern, of course, is from a community perspective, at what point do people become saturated? At what point does it become confusing to distinguish these different studies that often seem very similar and seem to have very similar goals and indeed are quite related? So that's something we definitely need to keep in mind as well. And was there any other point you had? Yeah, okay. So
Barry has already shared.
okay. Sorry?
Barry shared also some projects.
Right,
Yeah,
exactly. And the projects that Barry mentioned. Just a few minutes ago.
I really think our role in this project is really about create space for these synergies, and I think that's really important to take time to put around the table all these people and to create a momentum with that, because that's strength. That's not a weakness. That's really a strength in each city. So
great. So I'm not seeing any more comments or questions. Yes, okay.
wait.
So Rias writes, one thing to consider is the policy environment in each site.
Yeah, that's the phase
I'll
two.
just finish reading
Yeah,
this.
sure.
In Quebec, we're currently planning the next 5 years in public health, including HIV prevention. I think Ontario is coming with a new HIV strategy. Yeah. So
that's exactly the focus on the phase 2 we talk about sooner. I think we have this summer we have to take time to document the political context and to put together all guidelines and new politics and new strategies, and because we know what happens here in Quebec, but these factors will be really important in the future, and they will influence anyway the access at services and everything. So yes, we have to do that. I begin to talk with Marie-Lou Gagnon and Michael Orsini. They are from Ottawa, and they have expertise in governance, HIV governance and politics. So they will help us to have a nice conceptual framework to organize all this information. But you know, we are in the field and we need to do this job together. The data will come from us and our analysis of that, not an external studying of that.
okay. So just to conclude, thank you very much, everyone, for participating today. I'm really excited, especially given just the little discussion that we have started to have on this limited format of a webinar. Thank you to Coxida for the use of the webinar system, to Aurélie for all of her support and technical. And we have a final comment, great project. What are your general expectations towards us, roles, tasks, level, implication in the former, next steps of the general project? A really important question, and
I think we have to define this case by case.
Yeah.
I don't know. We need to meet each of you and to see where you find a place for you, and we will be better able to explain what your expertise is really important, and at what moment we will be able to really engage each of you.
I think one thing in terms of mobilities that we have realized is, and this touches on the idea of committees. So rather than setting up standing committees with kind of maybe a sort of a vague or ongoing mandate, we really switched to focusing on what's the ponctuel, on the provisional committees, occasional committees, or to sort of bringing together people who are interested in specific aspects of focus on a sort of limited basis to work on specific aspects. So we've got one that's focusing on qualitative data analysis, another on quantitative data analysis, another one that's looking at kind of partnership agreements and collaboration in terms of sharing of data. So that's been effective in terms of having a sort of supple kind of structure and flexible, and people are able to participate kind of as intensively or as minimally as makes sense for them. And we have it, so it also lays a way for people to maybe be intensively involved at some points and then less involved later. So I think those are approaches that we can communicate and maybe look at for the relevance in other settings. So great. So I think we'll wrap up. And again, we'll send you the slides, we'll send you the recording of the webinar, and of course, information about the upcoming meetings in June. So thank you again for your participation. I should be looking in the camera, but I'm not used to being a newscaster. Thank you for being with us, and look forward to talking to you again soon.
Merci tout le monde.